Hello friends, today we will discuss about pharmacokinetics and our main objectives will be to give a brief introduction of pharmacokinetics, to study the concept of absorption of drugs, to study in detail the distribution of drugs, to study about the metabolism and excretion of drugs, to study about the kinetics of drug elimination. So, first and foremost, an introduction about the pharmacokinetics. Safe and effective drug treatment is not only a function of the physical and chemical properties of drugs, but also a function of how the human body responds to the administration of medication. The study of the bodily processes that affect the movement of a drug in the body is referred to as pharmacokinetics. Pharmacokinetics comprises all processes that contribute to the time course of drug concentrations in various body fluids, generally blood or plasma. That is, all processes affecting drug absorption, distribution, metabolism and excretion. Absorption, distribution, metabolism and excretion are sometimes referred collectively as ADME processes. These processes determine when the drug appears in the bloodstream and for how long it remains there. In order for a drug to cause a therapeutic response, it must reach adequate concentrations so that it can reach and interact with drug receptors in adequate numbers to trigger a noticeable action. Coming to our second objective, that is to study the concept of absorption of drugs. Absorption is the transfer of a drug from its site of administration to the bloodstream. The rate and extent of absorption depends on the route of administration, the formulation and chemical properties of the drug, and physiological factors that can impact the site of absorption. When a drug is administered intravenously, absorption is not required because the drug is transferred from the administration device directly into the bloodstream. Here, the entire dose of the drug is available to move to the site of drug action. Administration by other routes may result in less availability due to incomplete absorption. When this occurs, less of the drug is delivered by the bloodstream to the site of action. When a tablet or capsule is swallowed, it must dissolve before it can be absorbed. The dissolving of a tablet or capsule is referred to as dissolution. Manufacturing processes and water solubility of the drug affect dissolution rates. Liquid preparations do not require the step of dissolution. This explains the more rapid onset of the action seen with liquid formulations as compared with the same drug given in tablet or capsule form. Once dissolution has occurred, the drug molecules must pass through the selectively permeable membranes of the cells lining the gastrointestinal tract to reach the bloodstream. Depending on their chemical and physical properties, drugs will be absorbed either by passive diffusion or carrier-mediated transport across these membranes. The relationship between the drug dose and the amount ultimately delivered to the bloodstream is defined as bioavailability. If 1 gram dose of a drug is administered by mouth and half of that reaches the systemic circulation, the drug is 50% bioavailable. Now we will study in brief about the factors affecting absorption. A number of patient-specific factors can affect absorption. Absorption from any site of administration requires blood flow. A patient who is in shock or cardiopulmonary arrest will need to have medications administered intravenously to achieve the desired response because of the reduced blood circulation in these situations. Most absorption after oral administration occurs in the small intestine because of its large surface area and therefore greater blood flow. Significant impairment of absorption can result when sections of the small intestine are removed for medical reasons. Contact time with the epithelial lining of the GI tract is also an important factor in drug absorption. Some medications exhibit drug-food or drug-drug interactions with other compounds present in the GI tract. Specific foods or other drugs may bind a drug and prevent absorption. The interaction between tetracycline and dairy products or antacids is a good example of this effect. Coming to our third objective, that is to study in detail the distribution, metabolism and excretion of drugs. Once a drug is absorbed into the bloodstream, it can be carried throughout the body. This process is called distribution and it is a reversible process. The delivery of a drug from the bloodstream to the site of drug action primarily depends on blood flow, capillary permeability, the degree of binding of the drug to blood and tissue proteins and the relative lipid solubility. Blood flow to different organs of the body is not equal. The most vitally important organs of the body receive the greatest supply of blood. These organs include the brain, liver and kidneys. Skeletal muscle and bone receive less blood and adipose tissue receives the least. If blood flow was the only factor affecting distribution, it would be reasonable to expect that higher concentrations of administered medications would always appear in the brain and liver. However, in reality, only few drugs exhibit good penetration of the central nervous system. The anatomical structure of the capillary network in the brain creates a significant barrier to the passage of many drugs and is commonly referred to as the blood-brain barrier. Now we will discuss about the factors affecting distribution. The blood is composed of a number of elements including plasma, red and white blood cells and plasma proteins. Most drugs reversibly bind to plasma proteins in varying degrees. Albumin is the plasma protein with the greatest capacity for binding drugs. Binding to plasma proteins affects drug distribution into tissues because only drug that is not bound is available to penetrate tissues, bind to receptors and exert activity. After discussing the distribution, we will now discuss about the metabolism of drugs. Drugs are eliminated from the body either unchanged through the kidneys and bile, or they may undergo chemical changes that allow them to be more easily excreted. The process of undergoing chemical change is called biotransformation or metabolism. Anything absorbed through the GI tract goes directly into the portal circulation that feeds into the liver. The liver is adapted to clear toxins from the body and is a major site for drug metabolism. There are two types of metabolic processes through which drugs undergo in the liver. In the first type of reaction, drugs are made more polar through oxidation reduction reactions or hydrolysis. These reactions use metabolic enzymes, most often those of the cytochrome P450 enzyme system, to catalyze the biotransformation. In enzyme catalyzed reactions, the rate of the reaction is accelerated by the presence of enzymes. A limited amount of enzyme is present at any given time in the liver. Since the rate of enzyme catalyzed drug metabolism is limited by the quantity of available enzyme, metabolism in these cases is considered a saturable process. This means that the rate of conversion will only continue at the normal pace until the available supply of enzyme is used. Examples include metabolism of alcohol and phenytoin. The second type of metabolism involves conjugation reactions. In this type of reaction, the drug undergoing change is joined with another substance such as glycouronic acid, sulfuric acid, acetic acid, or an amino acid. Glycouronidation is the most common conjugation reaction. The result of conjugation is a more water-soluble compound that is easier for the kidneys to excrete. Now we will discuss about the factors affecting metabolism. Metabolism of drugs can vary widely between different populations. Deficiency of some drug metabolizing enzymes is genetic and will result in poor tolerance of certain drugs. For example, many Asians and Native Americans have difficulty in metabolizing drugs that require acetylation, such as ethanol. Age is another important variable that has a bearing on metabolism. Organ function gradually declines with age, and the elderly may poorly tolerate drugs that require metabolism. The very young require special consideration of drug dosing because of immaturity of their organ systems. After discussing the metabolism, we will now discuss about the excretion or elimination of drugs. When a drug is taken into and distributed throughout the body, it must be subsequently removed, or concentrations of the drug would continue to rise with each successive dose. The complete removal of the drug from the body is referred to as elimination. Elimination of the drug encompasses both the metabolism of the drug and excretion of the drug through the kidneys and to a much lesser degree into the bile. Excretion into the urine is one of the most important mechanisms of drug removal. The kidneys act as a filter for the blood and create urine as a vehicle for removal of waste. Blood enters the kidney through renal arteries and then is filtered by the glomerulus. The glomerular filtrate becomes concentrated and substances are removed as it passes through the renal tubule. Drug molecules in the bloodstream that are not bound to albumin are also filtered out into the glomerular filtrate. When a medication is given repeatedly, the total amount of drug in the body will increase up to a point and then stabilize. At this point, the amount being taken in by the patient is equal to the amount being removed by the liver and kidneys. This state of equilibrium is called steady state, and drug levels will remain fairly constant unless there is a dose change, an interruption in treatment, or failure in the organs of elimination. Now we will discuss about the factors affecting excretion. The complete elimination of a drug from the body is dependent on normal liver and kidney function. When a patient has reduced kidney function or another problem that lengthens the half-life of a drug, dosage adjustment is required. If the dosage is not adjusted, the drug will accumulate in the body. Age is another important factor that affects excretion. The very young and very old will have lower rates of excretion, the old because of deterioration in organ function and the very young because the kidneys have not reached full maturity. Doses often require reduction in these patients. Drug interactions such as when multiple drugs compete for metabolic processes can also reduce drug removal. Coming to our last objective, that is to study about the kinetics of drug elimination. Time course of drug clearance, that is absorption, distribution and elimination, can be determined in mathematical terms. Such a determination is important, having clinical significance in understanding and planning drug regimes, in deciding drug dose schedules, and in helping and supplementing to clinical monitoring and judgment. In fact, drug elimination or drug clearance is the sum total of metabolic inactivation and excretion. Drug clearance is the theoretical volume of plasma from which drug is completely removed in unit time. It is usually expressed as ml per minute. For example, if drug clearance of verapamil is 1000 ml per minute, it means that verapamil from 1000 ml of plasma is removed in 1 minute. Kinetics of clearance follows first order or exponential kinetics. In this case, the rate of elimination of a drug is directly proportional to its plasma concentration. It means that a constant fraction of the drug in the body disappears in unit time. These drugs have a constant plasma half-life. Elimination of most drugs or drug clearance follows first order kinetics. In this case, the processes involved in removing most drugs are non-saturable over the clinically obtained plasma concentrations. Zero order or linear kinetics. In this system, rate of elimination of a drug or rate of drug clearance remains constant irrespective of its plasma concentration. It means constant amount of the drug is eliminated in unit time. This is also called dose dependent elimination or saturation kinetics. In this type of elimination of a drug, drug clearance decreases with increase in its plasma concentration. Further, the plasma half-life is not constant and there occurs increase in biological half-life with an increase in the dose of a drug. plasma half-life. It's also called elimination half-life or biological half-life. It is defined as the time taken for the circulating plasma concentration of a drug to fall by 50%. When drug clearance is exponential, plasma half-life is independent of dose, route of administration and its plasma concentration. The duration of half-life is raised if drug is widely distributed in the body, highly protein bound and follows anterior hepatic circulation. Mostly, half-life is indicative of duration of drug and helps in determining the dosage schedule. Steady state level. When drug is given once, it follows the following phases. Absorptive phase. There is a rise in plasma concentration. Distribution phase. A rapid decline in plasma concentration, and elimination phase, a steady decline in plasma concentration. Most of the time, drug is given in a fixed dose at fixed intervals or given by infusion at a fixed rate. So, on repeated administration, mean plasma concentration rises gradually. It depends on intake and drug clearance. Initially, intake is higher than elimination, so there occurs continuous rise in mean plasma concentration during this period. Subsequently, intake of drug becomes equal to its elimination or drug clearance. At this stage, a steady state level of mean plasma concentration is reached. It means the time to reach steady state level is a function of half-life irrespective of the dose or dose interval. Dear friends, this brings us to the end of the lecture on pharmacokinetics. Hope you have enjoyed. Have a nice day.